Hi, everyone, and welcome to another week of Psychopharmacology. This week, we're talking about the material in Chapter 13, which is on antidepressant, anti-anxiety, and mood-stabilizing drugs. As you can see from this slide, major depression is very common as a mental disorder, and so is social phobia. Falling behind, but not uncommon, are also the disorders like bipolar disorder, panic disorder, generalized anxiety disorder. And all of these disorders are going to be covered in this chapter. These are the disorders that are common in society, common in the United States, and also easily treatable with various medications. It's not to say that they're not difficult to treat. In some cases they can be, but there are lots of things that we can do to help individuals when they are dealing with a mental disorder. And certainly right now with COVID, there's just so many challenges right now that challenge people and sometimes bring about things like major depression. So we want to make sure that we help people when they are struggling and suffering. Now, there are a variety of reasons why people don't seek treatment, but a lot of times it comes down to cost, insurance concerns, and feeling the need that they don't need treatment. So in many cases, helping people is partly getting them to see that, you can go to the family doctor, you can see what's available for treatment, knowing where to go for treatment and not feeling like they need to be stigmatized for needing treatment. A lot of times, what is really critical is for someone to understand that if something's going wrong in their brain, it's no different than something going wrong in their liver. Your brain is a body organ, just like any other body organ, and sometimes things just don't go well. When that happens, you want to get treatment so that things can get back on track. So what are the common disorders? Of course, major depression is the one that's most common. 1 in 5 people eventually at some point in their lifetime struggle with major depression, where they are just for more than 2 weeks really feeling persistent sadness, loss of pleasure, decreased energy. They feel worthless, feel very guilty, and they withdraw from other people. It's really something that makes people feel very unpleasant. It's a lot of pain, and major depression is so common. So it's interesting that sometimes people feel stigmatized about seeking treatment, given that they probably know plenty of people who've been through exactly the same thing that they've been through. A little less common is bipolar disorder, where the person alternates between depression and mania, where the mania is like the opposite of depression: elevated mood, increased energy. And so in cases of bipolar depression, the person cycles from the one extreme to the other, and stabilizing mood is the goal of treatment. Then there are the anxiety disorders, and these are all the disorders where anxiety is a feature, of course. They can range from a generalized anxiety disorder, where the person is anxious and worrying all the time, to very specific situations like phobias, where there's a disproportionate fear of an object or situation, like maybe someone is afraid of flying or going into elevators. Then there are social anxiety disorders, where you fear unfamiliar people or social scrutiny. There's post-traumatic stress disorder, that after a very stressful traumatic event, the person struggles with flashbacks of that event, hyperarousal, great difficulty sleeping, feeling numb and anxious and irritable. And then there's panic disorder. Panic attacks are when you have sudden feelings of doom, apprehension, terror, and physical symptoms like heart pounding and dizziness. In a lot of cases, if someone's never had a panic disorder diagnosis and they have a panic attack for the first time, they actually feel like they're having a heart attack. It's really difficult to distinguish between a heart attack and a panic attack. And so in those cases, the person might actually be sent to the emergency room and see a cardiologist first before they realize that it is panic disorder. And all of these anxiety disorders, that anxiety is the pervasive problem, but it just depends on whether it's all the time or in a specific situation. And if there's something specific prompting it, like social situations, or a traumatic event that led to the disorder. In this chapter, we cover the mood and anxiety disorders together because there's so much overlap in clinical symptoms and in neurophysiology. When you look at people who are diagnosed with major depression, almost 60% of them also have an anxiety disorder and vice versa. So it is hypothesized that there's probably something common and underlying in the neurobiology that leads to maybe more depression in one person or more anxiety in another person, but underlying what is going on is the same. So if someone is diagnosed with major depression, the medications that can be used to treat mood disorders are the antidepressants. They will reduce the symptoms of depression. So as a therapeutic drug class, they're useful for helping people with major depression. They're widely used. Improvements, though, when someone starts taking these medications is incredibly slow. That is the real downside to antidepressant treatment. So you're elevating monoamine neurotransmitter levels in the brain, but you're not going to see any sort of immediate action. So the person is not going to really feel much better for several weeks. It's really frustrating for the person who is trying to get treatment and get help. There are 4 different categories of antidepressant drugs based on their mechanism of action. And we'll talk about each one in turn in a minute, but there's the tricyclic antidepressants, which are the original ones that have been on the market the longest. Monoamine oxidase inhibitors, which are a little less common because there are some reasons why people have to be careful using them with dietary restrictions. The more common category is the SSRIs and the SNRIs. So they're selective serotonin or selective serotonin norepinephrine reuptake inhibitors. Those are your typical drugs like Prozac. And then the atypical antidepressants are also used in this category. The mood stabilizer drugs are for people who are experiencing bipolar disorder. And so we want to stabilize mood, hence the category name, mood stabilizers. So again, super frustrating because these medications can take a month or more to show some effects. But they are widely used. And for people who have bipolar disorder, a lot of times these mood stabilizers can be very effective. And so very helpful to people to get them back into, normal mood states. Then you have the anti-anxiety drugs. So lots of different possibilities in the anti-anxiety drug category. So you have the anxiolytics that reduce symptoms of anxiety. You have the benzodiazepines that increase GABA activity. The benzodiazepines, though, are a bit tricky because the sedative effects, while they're going to dampen down anxiety, which is great, you want them to do that, they are going to also dampen down cognitive processing, motor skill processing. So, if someone's driving a car, they're going to feel kind of sedated and not quick to respond. This drug category also can cause tolerance and dependence. And so we worry about that people will escalate their dose to mitigate anxiety. And then also we get really concerned about them combining them with alcohol because both alcohol and benzodiazepines increase GABA. And so you can have overdose situations, which can be very dangerous. So a lot of times anxiety disorders are treated with SSRIs because they're a little safer and we'd have less concern about the tolerance and dependence. If someone has short-term anxiety, though, it may not make sense to give like a benzodiazepine or an SSRI. You might just want to give something that acts in the short term. And so an antihistamine actually works like that. So you might think of taking an antihistamine because you have a grass allergy or some other allergy. Well, it will also calm you a little bit, the antihistamine. So that's a possibility for if you have, anxiety in one particular short-term situation. And then there are other, possibilities like barbiturates, little less common because again, any of these cases, any drug that increases GABA is going to decrease anxiety, but then you have to worry about overdose. So these drugs have been around since the 1950s. They are a little you know, the treatment of mental illness is just really a mixed history. You know, we oftentimes have not done the best job in helping people with mental illness. We have seen historically that people self-medicated. So people drank alcohol, used other drugs if they had major depression instead of some sort of other treatment. It wasn't until the late 1980s that SSRIs were available. Widespread use became more common. And I think people are more willing to admit to having problems like major depression because they know that there's medication available to help them. So as I said before, depression is incredibly common. It's almost common. 20% will experience an episode at least once in a lifetime. It's called the common cold of mental illness. It is more common in women, and men are more likely to have substance abuse disorders. So, you know, sometimes when people look at that data, they think that women are more likely to admit that they're depressed. Men are more likely to drink too much if they're depressed. You know, so that's a consideration, understanding that sex difference. Also, higher income countries have higher rates of depression than lower income countries. So there is sort of that connection to depression and feeling like you need to compete with the rest of society, things like that. The differences in income levels that sometimes occur in higher income countries can be contributing factors. There's lots of different reasons why higher income countries potentially could have higher rates of depression. A little less common, the anxiety disorders, but still following close behind. Social phobia, 1 in 10 individuals have social phobia at some point in their lifetime. A specific phobia is actually a little bit higher, almost 16%, and again, more common in women than in men. So if someone is going to have treatment for major depression and they're going to take an antidepressant, or they're going to use an antidepressant to treat an anxiety disorder, the concern is the slow action on the drug effect helping the symptoms. And it's really frustrating because the side effects that come from treatment start immediately. So for the first 4 weeks of treatment, most individuals are complaining about side effects and not feeling any benefit of the medication. And it can be anything from dry mouth to feeling blurred vision, dizziness, weight gain. The list goes on and on. Several weeks later, though, hopefully the person is starting to feel better. And a lot of the research seems to suggest that the reason it takes so long is that the increase in serotonin levels, for example, are prompting new neurons to grow. And so you need that duration of time to pass because you need neurogenesis to occur, the making of new neurons, the birth of new neurons. Interestingly, when people go through chronic stress, there is damage that occurs to neurons. So it may be that the antidepressant treatment, the medications are reversing the damage that's occurred to neurons associated with depression. So this has been seen in areas of the brain like the hippocampus and other areas. And again, it's not a panacea though, because patients are different in how they respond. About 50 to 70% of patients experience major improvements in depression symptoms if they have a major depression disorder. But that means also almost half of people are not responding. So that's not a great response rate in some cases. Now, sometimes all you need to do is switch the medication, try a different kind. So maybe the medication that works on serotonin alone is not that great, but if you have another medication that works on serotonin and norepinephrine, it works a lot better. So there is a bit of trial and error that goes on, but it's not like the medication starts taking and then people are magically all better. It doesn't happen that way. For the MAOIs, the reason it's not as commonly used as a category is because you have to avoid foods that contain tyramine. So there's dietary restrictions. And some of the antidepressants, you have to be careful about the increased risk of suicide, especially in children and adolescents. You remember their prefrontal cortex is not fully developed yet. So they tend to be impulsive at that age range. And so a lot of times someone who's deeply depressed won't take action on suicidal thoughts, but when they start feeling a little bit better, they actually are more likely to take action. And so you have to watch children and adolescents in particular very closely. You have to worry about suicide in all individuals who are depressed. Close observation of someone who's not feeling well is really critical. Now, antidepressants may be taken for months or even years, depending on what is going on with the personal case of that person. Tolerance sometimes develops to the side effects. So the side effects that people experience may just go away. But little tolerance seems to occur for reducing the depression, the effectiveness and reducing the depression symptoms. So people can take these medications for not only months, but years and have good, effective outcomes. Again, just like the ADHD medications, you want to make sure that the person doesn't actually need the medication anymore. So you do want to eventually take them off to see if maybe they don't need that antidepressant anymore. But you don't want to take them off suddenly. If you suddenly have someone stop taking medication, that withdrawal will definitely lead to withdrawal syndrome. It's called discontinuation syndrome, where the person will feel sick. They will feel nauseous, vomiting. They'll have a flu-like illness. They'll have sleep disturbances. They'll be very anxious. So if someone is going to go off an antidepressant, it needs to be tapered very, very, very slowly. Decreasing that dose very slowly over time can avoid this discontinuation syndrome. Okay, so the pharmacology. So the whole goal behind antidepressant treatment is to elevate the level of the brain's monoamine neurotransmitters. So you want to elevate serotonin, norepinephrine, and dopamine in the brain. The idea of the depression is that those levels are deficient, and you're going to fix that by raising them back up to normal. So the tricyclic antidepressants are blocking the reuptake of norepinephrine and serotonin. The SSRIs are just going to be specific to serotonin. The SNRIs are more like the old-fashioned tricyclics in that they're going to block reuptake of both serotonin and norepinephrine. The monoamine oxidase inhibitors block the normal enzyme breakdown of these monoamine neurotransmitters. So instead of blocking reuptake, they block the enzyme breakdown. So there's more circulating neurotransmitter. And then the atypical antidepressants are a little less well understood, but to just give an example, Wellbutrin blocks reuptake of dopamine and norepinephrine. And sometimes, if someone is not doing well on only one medication and you've tried a couple of different medications, you might actually combine more than one antidepressant to see if you can get effective action. The acute and chronic effects of anxiety drugs are beneficial immediately. In one dose, you'll actually see reduction of anxiety within 15 to 60 minutes, depending on the drug. It will calm the person down, increase their muscle relaxation, make them tired because it's increasing GABA, calming the brain down. It may induce sleep, but the person is not going to have good sleep. Their rapid eye movement or dreaming portion of sleep is reduced. So they tend to feel very not well rested. This is very much like we saw in the alcohol chapter, where the person doesn't dream. And so they feel sort of hungover. They have memory problems. And so the memory problems can be very distressing to people. So they don't like those effects and they feel really groggy in the morning. It can interfere with cognitive abilities like driving, and some of the side effects are things like headaches or blurred vision, dizziness, GI upset, chest pains, and incontinence. So, there are a serious list of side effects that, for depending on the person, can be just an annoyance or serious for the person. Now, if you repeatedly use benzodiazepines, especially at high doses, tolerance is going to develop for sure. So physicians tend to, if they even prescribe a benzodiazepine, which many won't even prescribe one, if they do prescribe one, it tends to be short duration, a month or less, because you were going to have cessation of withdrawal symptoms, anxiety, tremors, insomnia, seizures. And you have to worry about that tolerance building up and then someone mixing it with alcohol or something like that. And the pharmacology of anxiety drugs is enhancing GABA activity, calming the brain down through GABA. So if you treat mood and anxiety disorders, ideally, it's not just medication. You want to know what's going on with the person. For some cases, they need to discuss what happened in their life that might have prompted the mood disorder. So psychological treatment would be helpful. Behavior therapy may be helpful if they are phobic to a particular object. Cognitive behavioral therapy would deal with some of the negative thoughts and ruminations. People get in these negative thought patterns, and it's really good to address them. Even electroconvulsive shock therapy can be used in extreme cases of severe depression. It is an effective treatment. And so you want to prevent efforts, concentrate on improving social and problem-solving skills, and help people's stress management techniques, let them be better at handling the ups and downs of life, because we all go through them, right? So if you are uncertain about whether you need help, the checklist here from the National Institute of Health is rather useful. You can look at, do I have mild symptoms? If so, are there some self-care things I can do that just tweak things? Are there more severe symptoms? Do I need to address things in more detail with a clinician's help? And seeking help can be, in a variety of different ways, and it can include medication.